Hi, so good evening, everybody. I hope you all can see me. I think it's easier if I put the video on, even though it's going to kind of run down my battery a little faster, but that's okay. So I think it's a little bit, makes the whole experience a little bit more intimate, a little bit more, maybe you can get to know me a little bit better and all these things. So we have a number of questions that you guys have proposed. So I'm going to be going through those questions. There's a number of subheadings and such to try and, I guess, signpost to make things a little bit easier in terms of your ability to be able to navigate through the talk. So it's mainly going to be based around your transition to clinicals, what to expect, specific things towards certain rotations. I'm going to talk a little bit about the kind of things that you're going to need, how to manage anxieties and various clinical scenarios that you're going to find yourself in. Talk a little bit about preparing to go abroad if you plan to go abroad, and that's not just for residency or for studies after medical school. I'm talking about elective, of which I did both my fourth year and my fifth year electives abroad, so I can talk about that as well. So yeah, let's go through all those things. So I think the SCOMA representatives are going to ask me the questions, and I prepared most of the questions already, so it's just for us to go through those. And I think if you have any additional questions, perhaps we can leave that to the end, or if you want clarification on something at the time I'm talking about it, you can just ask. Okay.
Thank you so much. Okay, we can start with the first question. How best do you study for rotations, for the different rotations, and what are the resources that you need?
Okay, so that's a really good question. So I think the best way to study for a rotation is actually to understand what is the expectations that they're expecting of you on that rotation. So obviously we're talking mostly about your junior clinical rotations, because this talk is mainly aimed for those who are going into junior clinical rotations. So your main objectives as a junior on your rotation is that you need to learn the differentials for common visits to hospital, whether that's through surgery, medicine, or pediatrics, any of those. So it's important for you to learn the different differentials. So for example, for medicine, common things is like cough, chest pain, shortness of breath, leg swelling, lower GI bleeding, upper GI bleeding. All these things are important things that people will usually present with. For surgery, it's stuff like abdominal distension, not passing stool, not passing gas. Obviously, trauma is a massive part of surgery also. People who are having problems with circulation to their legs, whether that be venous or arterial. There's lots of different things, but through being around and being especially like on the duties and such, you'll get an idea in terms of what stuff comes to A&E and what are common things, because when you're there on the ward rounds, you're going to find that you're going to hear very similar cases over and over again. Yes, occasionally you get the weird and wonderful, but that's medicine. But for the most part, is usually there's a set of bread and butter things which you will be expected to know in detail. So it's easier to know what's expected of you if you learn those differentials for common visits to hospital. Another thing that's important in terms of objectives for a junior student is that you need to learn to take history adequately. Yes, learning to do physical examinations is also important, but the goals of your junior clinical rotations is to be able to take a history adequately, so that when you become a senior on that rotation, it's more about the clinical management of the patient, honing your examination skills. That's what senior rotations are for. So for your junior rotations, honing your history taking skills is very, very important. And not enough people put a lot of emphasis on that. You know, they'll take a couple of histories and then they'll just kind of stop, because it's a lengthy process, especially when you first do it. It can take you up to an hour taking history from the patient. But, you know, I was doing histories with some seniors just today, via WhatsApp call, and they can take 20 minutes to take a history, which is great. So it's something that you have to practice, because without practice, you're not going to be able to do it within a shorter time frame. And obviously, when you become a doctor, you don't have an hour per patient to be able to be sitting and taking a history and then have to examine it and then have to do investigations. You just don't have that time. Another objective is also introducing yourself to the style of examination for that area. So nobody's expecting you to be an absolute expert on physical examination of a patient at the end of third year. They're not expecting it, but they want you to at least have some idea in terms of the order. You'll of course be tested that in your end of clerkship exams. People will always make mistakes. I've been in numerous end of clerkship exams for the juniors, and people always make mistakes, but it's about practicing. It's about exposing yourself. It's not even that important about finding the clinical findings. It's like, can you do the examination step by step like you're supposed to? Another thing in terms of best way to study the rotation specifically is that something that I found very, very helpful was to split things into systems or topic based, and that made life so much easier. So for example, for medicine, you could spend a week doing cardiovascular system, and through that you're going to do various different topics attributed to cardiovascular system. So hypertension, heart failure, valvular heart disease, these are common things. And then you pick a topic per day. So say Monday, you want to do heart failure. From you wake up in the morning until you can read no more, you're reading about heart failure. The types of heart failure, what causes heart failure, how do you investigate people for heart failure, how do you manage people for heart failure. Of course, as a third year, you don't really know much about management, because these drugs are like, oh yeah, I think I came across that in cardio sometime. Like, sounds familiar. I think I remember the receptors it works on. So it's about being able to pull that preclinical knowledge and put it in the clinical setting now. And then during that same week, when you're doing cardiovascular system, you could actually be practicing your cardiovascular examination at the same time. So during the daytime, of course, it will be filled with numerous activities, like consultant might want to have class, you might have ward rounds for the class, your resident might want to teach you, your study group might want to come together and do something. But what I used to do, I used to wake up early in the morning, because that's the best time for me. I used to study whatever topic it was for that day, go to the hospital, see my patient, so my patient, which is where you see the patient, you examine them, assess what their issues are for the day, and try and make a plan of what you want to do for them. I mean, your plan's probably never going to be taken into consideration, but you have to do it for case notes and all sorts of stuff. So I used to do that. And then me and my friends used to come together and say, okay, so this week is cardiovascular exam. So any free time we had when we're not on ward rounds, we're not in class, we used to find a patient and just do a cardiovascular exam. We don't know nothing about the patient. We don't know if they're a cardio patient or not, because that confuses things. When you're just starting out, it's very important for you to just learn the technique of doing things. It's actually even better for you to do it on normal people. So if you do it on your friends, your family, etc., those are the people to practice on. So that's what we used to do. We used to just practice cardiovascular system examination for a whole week. And we were terrible at the start of the week. It takes so long. It's supposed to take you 5 minutes. We're taking so long to do the examination. But your friends help to critique you, help you to remember different steps, and maybe they've been exposed to somebody doing it in a slightly different way. So through that, like, not a lot of people, like 2-3 people max is all you need, and you just practice it for that week. By that week, I mean Monday to Friday. So that's something I found very, very helpful. What else? Yeah, and then just as the week progresses, you start doing it to time. For the topics itself, books are important, of course, in terms of studying, but the recommended texts are recommended for a reason. I'm going to say that straight. They're very helpful. Loads of people have used the same books over many, many years, but sometimes it can be very daunting if you have this fat book and you're like, oh God, I haven't finished this by the end of this 8-week rotation. It's like, impossible. And every time you look to open that book, you're going to feel like, God, do I have to do this? And you'll be tired even from looking at the book, even before you've opened it. Okay, so something that I found, a bit of a cheat, but something that I found was very helpful, I'd like search the topic name, so say heart failure, and then put PDF after it. And when you do heart failure PDF, you get something that's 2 to 3 pages long, which is basically a summary of everything heart failure, or everything jaundice, or everything bowel obstruction. And I used to read through that first before I went to the textbook. So I had like a general broad idea of what I'm expecting. And then you can just build on it. Remember, medicine is just a building process. You can't forget the stuff from pre-clin. There's some stuff that you're going to leave in pre-clin, but it's a building process. If you think of it like a house, your pre-clin is your foundation. And then from there, you're just building your clinical acumen from there. So using those cheap PDFs really, really made my life so much easier, because sometimes you just don't have enough time to read 5 chapters on one topic. So and then the structure of rotation itself is if it's an 8-week rotation, what I would do, I'd spend the first 5 weeks of that rotation really trying to get to grips with the content and the examinations somewhat, but not like perfecting them or anything, but mostly the topics in that time. And then 2 weeks, which would take you to week 7, end of week 7, that's when you start doing your past paper questions, and you start honing your clinical skills in terms of what you were expecting to come in the exam, like clinical examination and stuff. And then usually the last week, there's no point in you learning anything new at that point, because your exam is like in the next couple of days. So usually week 8 is usually taken up just going over stuff you've already covered, moving into doing your exams. So that's what I would say for in terms of best way to study for the rotations. There's no best way, like absolute best way, that you have to find what works for you, and you're going to find probably that what you used in pre-clin is probably not going to work for you in clinicals. So I changed my study style about 3 or 4 times throughout med school because of that and other challenges that I had at the time. I don't regret it, because if I had stayed on how I studied for pre-clin, I really wouldn't have been able to apply that in clinicals.
Oh, okay. What are the skills that you recommend students have before they start clinicals?
Well, okay, so in terms of skills, you have probably never been exposed to clinical examination before, so it's something that you have to be shown. So yes, you can watch videos online and see if that makes life a little easier for you, but you'll find that UE, for example, has a specific way of doing things, and really only through being shown or using the departmental videos or the videos that I had made for my junior medicine group. Those are the kind of things that are really going to help you do it the UE way. Other than that, there's stuff like Geeky Medics. There's multiple videos out there which you can use, but they're not the UE way or the UE's way of examining. I think in terms of things to, what skills? I think a skill which is definitely underestimated by people is getting into a routine. A routine is a really important thing. And you may not see it as a skill, but it totally is. So, if you're used to waking up at 11, 12 o'clock in the day, that's not going to work when you get to clinical medicine. If you're going to bed at 2, 3, 4 o'clock in the morning, and you have to wake up at 7 o'clock to be at ward rounds for 7:30 or 8 o'clock, it's going to become very, very difficult very fast. So I would say, if I'm not saying from the beginning of summer holidays, but closer to the time when you're going on the wards, start getting yourself into a routine. If you're not used to waking up and eating breakfast, you're going to have to learn to start, because most of the time you're not going to have time to eat lunch. They're going to say lunch is a figment of your imagination and all of these things. Another thing that you're also going to have to do is training yourself to wake up from a nap and study. So like when I came home from the hospital, the first thing I want to do is eat and sleep. the first thing I want to do is not go to my book and study. You've been there all day. You've been standing up all day. You've been doing stuff all day. All you need to do is just sleep and rest. So I used to take a nap, but you have to learn to take a short nap. You can't take a 4-hour nap. That's not a nap, that's a sleep. Okay? And then to wake up and then study stuff. You have to find what works best for you. If you're going to take your main sleep at that point in the day, and wake up like 10, 11, and you work throughout the morning and then take a nap and then go to the hospital, then that's for you. But for me personally, it never really worked like that. I'd have to sleep properly at a normal hour of the day, and I used to wake up early because I'm an early bird, so I used to wake up from like 4 o'clock in the morning. But that's not for everybody, so you have to find out what works for you. Another thing is, in terms of skills, you have to make sure that you try and get the most out of the rotations that you're doing. Okay, you're not going to be spoon-fed the information anymore. I know throughout this COVID time, you've kind of not been spoon-fed anyway, because they don't turn up, or the connection was lost, or you fell asleep during the Zoom class, or whatever it is you guys have at the moment, right? So you're even less going to be spoon-fed at this point. Okay, so the residents don't have to teach you. They're also studying for their own exams. Yes, it's in their best interest to try and hone their skills by teaching you, but they don't have to. The consultants are scheduled for specific times to teach you. So that's when they're going to do it. But if you get a very good consultant, they're going to teach you on ward rounds and all these things. And then that makes life so much easier. What else? What other skills? Yeah, another skill is to learn to read around your patient, be interested in your patient. So if your patient comes in for pneumonia, go read about pneumonia, because, on ward rounds tomorrow, when they're asking you about your patient, they're going to be asking you about pneumonia. So that's another thing. Yeah, that's what I'd say for that.
Okay.
Yeah, that's right.
Right. So questions about not embarrassing ourselves, or questions about how to combat anxiety. How do we not embarrass ourselves around consultants? And the do's and don'ts.
Okay. I think for most people, what they're worried about for clinicals is that they're so afraid of being embarrassed, being called out publicly, or publicly shamed or humiliated on ward rounds. And that's something that at some point is probably going to happen to somebody you know. Okay? It doesn't have to be you, but it will probably happen to somebody you know. The first thing to understand is that you're learning. Okay? And that's something that I had to carry through from third year onwards, because some people had particularly bad clinical experience in terms of junior clinicals coming through. I'm talking about residents, consultants, etc. And they like to somewhat make other people suffer under them, which is ridiculous, but it happens. And they will say things like, oh my gosh, I can't believe you don't know this and all of this. You did this in pre-clin, why do you not remember? Do you guys just forget things these days? What other things have I heard? Back in my day, we never used to do this systems-based thing. We used to study for 2 years straight and do exams, whatever. That worked at that time. We're not doing that anymore. So don't make any difference. They're going to say stuff like that, and you're just going to have to develop a somewhat thick skin, and let it, like, what do you call it, water off a duck's back. Because at the end of the day, some of the things they're going to ask you about, they only know it because they were shamed on a ward round and they never knew it and they had to go read it. I will say personally, things that I didn't know, right, on ward rounds, I remember better now than things that I knew well. Right? So if you know, like, for example, 9 things, that one thing that you don't know, that's what's going to stay with you, because you didn't know, maybe you felt embarrassed, maybe you felt shame, or whatever it is, and it forced you to go and read, right? I took a stance with most of my residents and consultants who tried to, I guess, embarrass me or shame me or whatever. Like, for me, I was just like, I really don't care, because at the end of the day, I'm learning. And people who I respected more are those people who say, okay, you probably don't know this, but I think you should read this and let's talk about it tomorrow. Those are the people who I have more respect for, rather than those people who are just like, I can't believe you know this. You people are so dunce. And that's really annoying. And you're going to find it no matter where you go. And it's an unfortunate thing within this culture that people still do it. But yeah, you're going to have to build a bit of a thick skin. And the reality is, most consultants and residents don't expect you to know everything, but what they want to see is your willingness to learn. Okay, so you're going to have to, the things that they really dislike is cowardice. So like, they're asking you a question and you're just like, I don't know. I don't know. You're not even willing to give some kind of intelligent answer, or you're not willing to try to answer the question. And also another thing they don't like is this, some medical students get this general attitude of, I don't really care, I don't really want to be here kind of thing, like I could just be at home reading. You need to understand that from the point of clinical medicine is that it's an apprenticeship, right? You're only going to gain clinical skills by being at the hospital. And I can speak of that personally, because at the moment, of course, we have our new interns, and a lot of them have been out of clinical practice for a while. And it's like you have to go through things with them again, like taking blood, putting in IVs and such, because they've been out of practice for so long. Not that they can't do it, it's just the practice is just not there. So yeah, so there will be times when you're embarrassed. There's going to be times when you're going to feel horrible, but don't let somebody beat you down or make you feel like you shouldn't be in medicine or you're too stupid to be in medicine, because some people actually really get a kick out of that. Okay, so that's one of the things. For people who struggle with anxiety, the most important thing is that practice will build confidence. So yes, you're gonna mess up the first couple of times that you do things. I definitely didn't do things perfectly the first time I did it, but by doing more practice of stuff, whether it's examination, taking blood, putting in an IV, taking a urine culture, the more you do, the more you become more comfortable with it. And these are things that are going to make a difference between people in terms of your patients thinking you're a good doctor or not a good doctor. If you stay at home and you read and you get all the honors and the distinctions and all these things, great. But at the end of the day, the patient's going to judge you on your competence of clinical activities, whether that's examination, taking blood, etc. So it's important to actually get experience in these things to ensure that you are more comfortable, because in life, those are the things you're going to have to do. I think people who really do struggle with anxiety, like properly, like physically manifesting, it's important to know that anxiety it's a physical, emotional, psychological manifestation of a fear that you have. And you're going to have to try and identify what are those things that really trigger you. Which are the things that really trigger your anxiety? Is it not knowing a topic? Is it public speaking? Is it being asked a question on ward rounds and not knowing the answer? You need to find out what are your fears, what are your lions, and then try and see what are the steps you can take then to combat that kind of fear. I think in terms of the do's and don'ts, in terms of clinical medicine do's and don'ts, for do's, you need to make sure that you eat and get some rest. Above all else, if you pop down and faint on ward rounds like people do, junior students, when they just move to clinicals, there's always one person who don't eat anything from the night before on a long ward round on a hot ward with no AC, and the person faints, and it's embarrassing, right? And you're not going to feel great about it, and people are always going to remember and tell you about it and all these things, but it happens, right? So you have to make sure that you look after yourself first. Make sure you eat breakfast. If you're not a breakfast eater, you're going to have to become a breakfast eater really fast, because most of the time, as I said, you're not going to be able to get lunch. If you're not able to get lunch, you need to have other things, snacks, sweeties, anything in your pockets that you can just go to when you're feeling hypoglycemic on water runs. And trust me, it happens to everybody. Another thing is for do's, make sure you clock your patient that they've assigned you to. Make sure that you talk to your patient, find out what's going on with them. Make sure the patient knows you. Don't just go to the docket and start clocking the docket so you have a history to read, because sometimes the consultants will ask them, have you seen this person before? And the consultants will be like, and the patient will be like, nah, I've never seen them. And the patients are just being honest, but they threw you under the bus because you said you saw the patient, you said you examined the patient, so you'll be caught out. Okay. Another do is seem interested, ask questions. Remember, you're learning. I used to ask some dumbass questions and I didn't care. Because I'm learning, and I didn't really mind what people had to say if they thought they were going to laugh and say, why would you ask that question? Because at the end of the day, I'm learning. If you don't ask a 2-3-year-old why are they saying why all the time. We just answer them, right? So it's exactly like that. Try to maximize your time at the hospital. So when you're at the hospital, it makes no sense for you to go hide in a corner and go read your book. You can do that at home. When you're at the hospital, get the clinical experience, offer to do the bloods, offer to do the IVs, gather together with your 2-3 other friends and go do examinations. That's why it's so good it's so important to have a schedule that you stick to so that you can get things done. And then if there's nothing going on at the hospital at 2:00, you're done ward rounds, go home, take a nap, eat, and then wake up and study what you plan to study for the day. It don't make sense to stay at the hospital all day. You're not being paid, right? And exhausting yourself, and your feet hurt, your back hurts, it don't make any sense, right? So come to the hospital with a plan, do what you're supposed to do for the plan, and go home. And definitely be punctual, right? Be punctual to ward rounds, be punctual to whatever else, classes or whatever. You need to make sure you're there on time, because those things affect your assessments. And sometimes, say for example, you're borderline in your exam, your assessment may just tip you over and let you pass the rotation. So it's important that you have good assessments from your consultants and your residents, so that if you're in any kind of problems regarding your exam, you can at least pass the rotation. The don'ts: don't be late, don't be scruffy, don't be untidy, don't be lazy, but also don't be overconfident, right? And it doesn't make sense for you to skip multiple days of clinical experience at the hospital to stay home and read. Remember, you're no longer in pre-clin. You're not. Yes, you're going to get overwhelmed with the sheer amount of topics that you're supposed to go through, but at the same time, it doesn't make sense for you to stay home and read all day, because for most of the day, maybe you'll stay on one topic and you really won't get anything done. So that's what I'd say. We've all done it. We've all missed 1 or 2 days of school, probably not consecutively, because you're tired and whatever, and you never wake up in time and all these things. Everybody's done it. But you just remember you're on ward rounds now, so there's no sleeping out through your lectures as you would have done in pre-clin, where you can just sit in the lecture or sit at home and log in at the moment, or turn on to the lecture and you can sit there and fall asleep. Those things don't work anymore. You can't fall asleep on a ward round, right? So these are things that I'm not above, right? I'm not above these things. I used to sleep in lectures in pre-clin. I've missed maybe 1 or 2 days from school, because making sure that you have to read through a whole bunch of things that maybe you didn't stay on your schedule to do, or maybe you're just tired, maybe you're unwell or whatever. But just make sure it's not like a consistent trait, because when it becomes a consistent trait, people are going to notice, and then it's going to go against you in the long run. Okay.
Okay. how true are the stories of students being asked to leave the ward rounds if they don't know how to answer questions?
Okay, well, there's definitely some truth behind that story. I've seen where a consultant told everybody to go home because nobody had clocked their patient, nobody had read up on the condition that the patient had. Those are the kind of things that you're going to be sent home for. It's not about just simply answering questions on ward rounds. It's the fact that you never showed any interest whatsoever. You turned up, you expected to be spoon-fed, you expected to get information on the ward round, and you did no background work. Those are the things that you will be sent home for. And it doesn't happen. It's not every consultant. Some consultants will just be vexed and just completely ignore you. And remember, it affects your relationship with your consultant. Once your consultant sees you're willing and you're interactive and you're asking questions, that's the person who's going to stay late at the hospital and teach you how to do physical examinations and give you pre-exam hints and all these things. Those are the things that you want, but you have to put in some groundwork first.
Okay. Just one thing. The meeting will end at about 6:35, 6:40, and I would ask for each person to just click on the link that was the second link that person sent in the group to rejoin. Okay.
Okay.
Um. Okay. So we're going to move on to questions about preparedness. What
Sure.
are the top 5 recommendations do you have for persons who are starting clinical years?
Okay, so my top 5, my number 1 above all else is your mental and physical health must come first. It must come first, okay? So if you're stressing out and you're having a really tough time or whatever, you need to seek help and seek somebody to try and assist you to get through that. You cannot become burnt out and not helpful to yourself or anybody around you. For the sake of one rotation. I'm not saying you need to miss out an entire rotation. I'm just saying you need to be smart about your time. If you're feeling particularly exhausted, maybe you've had a really tough week, you need to sleep. And maybe that means sacrificing a night of studying. Maybe it does. But it just can't become something that's consistent. My number 2, create a routine and stick to it. Consistency is key in clinical medicine. Consistency is key, okay? So you're gonna have to, I'm not saying like schedule every minute of the day. I'm saying, okay, so today I plan to do heart failure. So you read everything you can on heart failure from dawn till dusk, right? And you make notes or whatever it is, and then maybe you put aside Saturday for you to read back over the things that you covered Monday to Friday, and then Sunday you prepare for the week ahead. So that's what I used to do. I used to pre-read. Say, for example, we're doing cardiovascular system this week. I just keep using that example because it's really easy. So on Sunday, be like, okay, I plan to do these topics for this week. Maybe I'll read through the PDFs, 2 to 3 pages of each one of them. And then in the week now, as I get to those days where I'm planning to do, say, heart failure, I'm going to read my textbook now or other sources up to date, all these important things, Medscape, to try and gather more information towards that topic. And then on the Saturday, I would put that aside to just read over the stuff slowly that I covered in the week to try and somewhat consolidate stuff. Yeah, that was pretty much it. That was pretty much it for that. Number 3, buy a pair of comfortable shoes that are not Crocs, that you can use for everyday use. Some consultants are really, really against Crocs, and that's why I say not Crocs. So you need to find very comfortable shoes because you'll be standing for a long period of time, and it happens a lot. People have back pain, their feet feel like their feet are on fire. I remember always the first set of WhatsApp statuses, right, that go up on the first day of internship, the first day of clinical medicine is, oh my god, my feet are on fire. And you'll see so many people will put that post because that's how it feels. You feel like your feet are on fire. So I don't have a particular brand, but you need to find out what works personally for you. Or if you can't find a shoe then perhaps get like an insole, like a Dr. Scholl's insoles and stuff, to try and cushion your feet. Number 4, every day try and fulfill the task that you set out for yourself. Okay, that's why it's important to have a set of things that you want to do, set of goals for the day. So for example, I want to do cardiovascular examination today. You know that when you go to the hospital, even if you do one examination, you would have fulfilled what you wanted to do for the day. But you need to have a plan, because otherwise you go there and you're sitting around and you're waiting, and the consultant says, oh, we'll run at 10, and you get ready for 10, and then they're like, oh, it's going to be more like 11, maybe 11:30, and you're like, what do I do now, right? Rather than just sitting around doing nothing, know that you have a plan in place so you can go and do something in the meantime when there are delays. And there will be delays, because these are people, these are humans, they have multiple other things going on. If you could just remind me what the question was, please.
Oh, what are duties like?
Oh, yeah. Okay. So you're expected to stay until at least 8 to 10 o'clock. It depends on the rotation. For emergency medicine rotation, it's actually what you'll do is a 24-hour duty. So it's called a graveyard shift. So you be on from 4 o'clock, and then you go to the next day, and then you go through classes the next day, and then leave at 4 o'clock after classes. So that one is pretty rough, but most of the time you're not obligated to stay extremely late, but you're going to find that there are benefits in staying later. So between 4 and 8 or 4 and 10 o'clock, you're going to get exposure to lots of cases that come through A&E, because that's mainly where you're going to situate yourself. Yes, there's going to be stuff to do on the wards, like IV accesses and stuff, if you need to get your procedures sheets signed up and stuff, but most of the time you are going to spend your time in A&E, and that gives you the opportunity to be able to clot the patient for the first time, examine the patient for the first time, and get those findings just as they come in. So yeah, that's for duties. And what was the second part of the question? I can't remember.
Are you allowed to do rotations abroad?
So yeah, you can do rotations abroad. None of your set clinical rotations you can do abroad, but there is something called an elective, which is something you can look forward to, either in 4th year or in final year. Most people use their elective to brush up on like something that they don't really know very well. Like for example, if you had trouble on medicine or trouble on surgery, they usually spend time in medicine or surgery to brush up on those things. However, I would suggest that you do your elective in something that you're interested in. Because, so for example, when I was interested in finding out what I wanted to specialize in, I did my electives in different stuff. My junior elective was done in pediatric surgery, and my senior elective was done in something called fetal maternal medicine, none of which I want to do at this point, but had I not had experienced them, I wouldn't know that. And what that allowed me to do is that I could immerse myself fully in something that I was interested in at that time. And then when I came, that allowed me to go through my day without being exhausted. If you're doing something that you already find difficult and you crawl through it all through the day, and then you've got to go home and you've got to open your book and try study the same thing that you're not really enjoying already, it's going to make your elective very long. It's going to be very boring. So I'd suggest you do it in something that you like, so that you can learn as you go along. And then when you come home, maybe then you can tackle the stuff that you're having trouble with, because your elective is really a time that you can consolidate things that you don't really understand that well. So I don't know. That's how I would take it.
What happens if I fail a rotation?
Okay, so if you fail a rotation, it's not the end of the world. So yes, lots of people are going to be aiming for the A's and an A plus and blah 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 in rotations, which for most people you're going to find that that's unrealistic. Passing the rotation is the most important part, because that's what earns you the right to get to the next step. So I'd say that part first. if you unfortunately fail a rotation, there is always the opportunity. It depends which portion of it you fail. If you fail the examination or if you fail the MCQ, usually, say for example, you did a pediatrics rotation and you failed pediatrics, but you're now on medicine, there's an opportunity for you at the end of the next 8-week rotation to do that pediatric examination again to try and pass. When you're in 4th year now, there's the option also for you to use your elective for you to complete the rotation that you failed. But your aim is not to fail, okay? You need to aim to pass at least, and that's why it's important to be around, because this is clinical medicine. It's not just an MCQ anymore. They're going to judge you on your examination skills, your ability to do things, and the only way you're really going to learn that is by being around. And you can always tell those who are around and those who were not around. Like even from the interns that we have now, I can tell who was around and who was not around. So, yeah.
Okay. To what extent do you actually, a question from the chat, are the examinations timed?
Yes, you have 5 minutes to examine and 2 minutes to explain your findings.
To what extent do you actually contribute to a patient's care and like diagnosis?
Well, let me give you a story for this. So I had a patient who was in ICU, was previously in ICU and then was discharged to the ward. So I examined this patient and spoke to this patient every single day. And one day I came to him, he was acutely short of breath. He was breathing very, very hard. He was hypoxic. I was turning up his oxygen and all these things. And I said to myself, maybe this man has a pulmonary embolism. But the senior resident at the time when we did ward round, she said, oh, probably it's worsening of his heart failure. Just give him some Lasix. He'll be fine. And I said to my intern at the time, I said, something's just not right. I think this man has had a pulmonary embolism, which is a clot that has dislodged from usually a deep vein, whether in the pelvis or in the leg, and gone and blocked somewhere in the lungs. And she was like, you know what? That could be true. And, you know, the patient was very, very sick. We did an arterial blood gas on him, and it showed that he was very hypoxic. We started him on a heparin infusion, and we sent him for a scan of his lungs, which showed that he had an extensive pulmonary embolism. And had I not have been the student, this is as a third year, if I hadn't been seeing that patient every single day and made the suggestion, perhaps it would have been missed, okay? So it's kind of important, because remember, at the end of the day, you are the person who is probably going to know more about your individual patient than the residents on your phone. Remember, they're seeing 5, 6, 7 patients every single day. It's hard for them to know the intricate details and the very minute changes that may occur in each patient. So you do have a contribution to make, especially to your particular patient that you're assigned to.
Okay, so which rotations are the most difficult in each year, based on your experience?
Well, remember that all depends on what you find difficult, right? So most people would say for your junior rotation that medicine is the hardest, because medicine is the largest ward, okay? For me personally, my hardest third year rotation was probably pediatrics. Not because I don't like children, I love children, but I just found pediatrics particularly difficult in terms of all the intricate details that are related to treating children, and you're also having to manage the family setting. So parents are usually very annoying and all these things. So yeah, pediatrics is probably all through medical, probably my most hated rotation. But I actually love kids, but I could never eat. For fourth year now, I mean, I had a particular difficult time with anesthesia, but that was mainly through my personal experience having been a patient in ICU. Going back to ICU, it was particularly difficult for me. But other rotations in fourth year that were kind of difficult. So ophthalmology is not difficult based on the content, it's more difficult based on the lack of teaching or inconsistency of teaching. What else is hard in fourth year? Trying to remember what rotations are in fourth year, really. Emergency medicine was hard only from the point of view that you have to remember lots of algorithms. So it's a lot of swatting stuff, and I'm not very good at swatting stuff. So yeah, that was difficult as well. So I think it really depends what are your strengths and what are your weaknesses. If you have particular strengths towards, you know, anatomy and stuff, then surgery is probably going to be pretty easy for you. I didn't find it particularly hard, having had the basis in anatomy previously, but it's not something that I would see myself doing in the future. And then in final year, again, probably pediatrics, but that's mainly again because I never really enjoyed it.
At this time, I want persons who have questions to just please add them to the chat. One of the last questions that we have is, what information do you have about getting into residency locally?
Okay. Well, I don't really have much information about residency locally. Usually, residency is going to require you to pass through internship and then SHO. And then from there, you then apply for a residency post. But I'm sure many of you have seen the articles recently about doctors being unemployed and such. And that mainly happens to those people between the SHO into residency bracket. And that is because in order to get a place in a residency, you require another resident to matriculate for the spot to become open. They don't just create residency spots because there's a certain amount of spots that are funded by Ministry of Health every single year. So you require the senior residents to matriculate and become consultants or resultants or whatever you want to call them, because most of them don't get consultancy posts because of the same issue. They pass their DM2 exam, which is the second exam to become a consultant, and a lot of the consultants are not resigning or not stepping down from their positions. You have people who are, 70, 80 years old and are still practicing. So because those positions are not available for them, they end up in chief residency positions or they work in private practice or whatever. But essentially, yeah, that's what you need in terms of residency to practice here. There's no special exam you have to do. It's important to try and get experience in your area. If, say, for example, the only time you really get choice to do that is SHO. So for surgery, for example, if you want to do surgery, you have to do a surgically related specialty. You can't do gen surg because it's not available at an SHO level, but you could do like neurosurgery or urology or cardiothoracic surgery to gain, or even anesthesia, to try gain experience of being in a surgical field or surgically related specialty, so that you have experience behind you when applying for residency. If you're planning to do it abroad, of course, it depends on specific exams you want to do, whether that be USMLE or PLAB. PLAB is changing come 2023, I think. So whatever that changes to. Most of them you're going to have be required to do these foreign board exams before you can get a position abroad.
Someone is asking specifically about England. Like, do you have any advice there?
Well, I did a previous talk with SCOME about preparing to go to England, and so maybe that person can probably contact one of you and get the PowerPoint from that. It's a two-step process, really. You have PLAB 1, which, well, I can only speak of what it is now because it's changing. PLAB 1, which is an MCQ exam, is 180 questions, about 3 hours to do it, which is totally doable. And it's from all areas, so medicine, peds, surgery, psychiatry, ethics, all those things. And then PLAB 2 now is a station clinical exam based on different skills like counseling patients, examining patients, taking a history, breaking bad news, counseling a patient who wants to stop smoking, down to like actual physical examination, not physical procedures like taking blood, doing CPR, those kind of things. But PLAB only allows you to get to the level of an SHO. That's what that exam is for. To get into a residency now, you have to do your Royal College exams, whether that be MRCP, MRCS, all of these different Royal College exams to become a member of a Royal College, and then you can enter a residency program.
Okay. What order of what's that? What's the order of rotations do you recommend?
For which year?
I guess for year 4 and year 5.
Oh, okay. So for year 4, I did pathology and microbiology first, which was a good way of having it. I guess I felt like it was a good setup for the start of the year. Where did I go from there? And then I think I did all the hard ones in the first half of the year. So I did emergency medicine. I did anesthesia, orthopedics, ophthalmology, did all of those, and I ended on elective at the end of 4th year. And then in final year now, I wanted to get those that require me to do lots of physical examinations out of the way first. So I did, what did I do? I did pediatrics first, I think. Can't remember. Did pediatrics, then I did medicine. Then I did my elective, which I did in a subspecialty of obstetrics and gynecology, which allowed me to practice and review all of obstetrics. And then I came back and did obs and gynae, but mainly gynae rotation, and did all the gynae topics for the first time. Then I did, and then I ended on surgery leading up to exams. So it worked for me, it doesn't work for everybody. And it's not, you don't always have the choice of what rotations you get, because it really depends on what is offered to you.
Can you enter residency in the UK without doing PLAB?
Yeah. You can do the MRCP or MRCS exams without doing PLAB. The reason I would say do PLAB first or PLAB equivalent first is that it allows you to be able to work whilst getting ready for the MRCP exam. For example, MRCP, MRCS exams are heavily weighted on protocols that are conducted within the national health system in the UK. So it helps you to have experience of the national health system while studying for those exams. So that's the main reason why I did PLAB, was so that I could work as an SHO in the UK while studying for my residency exams, and then apply for residency after that. But you can stay here for SHO, maybe do a year as a medical officer whilst you're studying for those exams. It's just going to be difficult for you because it's going to be a little bit out of context.
Sorry about that, I was muted. Someone is asking, is it that the university will provide transportation for you to get home after duties, or do you always have to find your way home?
So the university is supposed to transport you back from anywhere that you're doing a nighttime duty. There are some places that you just don't stay in the evenings for duty. So for like Spanish Town, you don't stay there. KPH, most of the time, they'll come and pick you up at like 8 o'clock-ish, or Bustamante, and it's the same bus that would take you to the rotations in the morning. If you do own your own car, if you have a friend who has their car, it makes life so much easier because you can leave at your leisure and come back at your leisure. So, but yeah, most of the time they will try, there should be transportation. I say that, should be transportation to take you back from wherever you're doing duty.
And for the Huskies, is it possible that person you will get a patient or a condition that you've never been exposed to?
Yeah, it is possible that you can get something that perhaps you personally have not had experience of, but somebody else has had experience of. For example, I find like MBBS, some people got neurofibromatosis, and they've never seen a patient with that, but they've probably read about it before. And then, And so therefore, for some people, that can be particularly challenging if you've never been exposed to something like that before. But it's the same approach. You just take the same approach in terms of explaining what you see and using descriptive words that you've picked up over the time that you've been in clinical medicine. That's really the best approach to it. Don't be startled, don't be afraid. Just comment on what you see, comment on things that you are experiencing in terms of these findings that you pick up, and there's nothing more you can do, and then just try and put them together and try and think what the patient could have.
Okay, so what's the process like to apply for overseas elective?
So it's a lengthy process. It depends on where you're going. I can only speak for England because that's where I went. So I had to apply a year in advance to all of my elective placements. So for an elective at the end of fourth year, I had to apply when I was in third year. So it's important to do your research early, because especially for most people, they're going to be required to get visas in advance. And that's really what takes up the bulk of the time. It's not sorting out the rotation. It's mainly sorting out the paperwork associated with your elective. It also depends also on your budget. A lot of places that you go to are going to require you to have some kind of elective fee. So you need to find out what it is you plan or want to be able to pay to be able to do a rotation abroad. If you can, I would say definitely do it. Whether it's the US, Canada, some other country, try doing elective abroad, because it allows you to have another perspective of a different health system. I know that there are people who come from England to come here who really appreciate the experience of being in a different country.
Okay, thank you, Dr. Smith. At this moment, we'd like to ask any other questions, throw the opportunity out. Okay, if not, at this moment, I'll call on Samara Ennis. Samara, are you here?
Yes, I'm here. Can you hear me?
Yes, we can.
Okay. Good evening, everyone. Okay, so on behalf of the medical preclinical students and the Burnout and Wellness Committee, I would just like to say a big thank you to Dr. Rochelle Smith for that very insightful and fruitful talk about what to expect during our clinical years. I can definitely say that we have learned a lot. We will definitely remember to take sweets in our bags or pockets. Also, we will remember to be punctual, modest, tidy, and definitely remember to wear comfortable shoes. And most importantly, we will remember to ensure that we take good care of ourselves. This has been very fun and informative. And as you wish us a very fulfilling and enjoyable journey throughout medical school, we would also like to say we wish you well and the very best in your future endeavors. So thank you again, Dr. Rochelle Smith.
No problem. Thank you, guys. Thank you for listening.
Dr. Smith, before you go, there's one last question. Did clinicals provide enough exposure for you to be sure of which specialty that you want to be in?
I think so. I think that through both my personal experience as well as my clinical experience, I really was able to make the decision of what I wanted to do. If you have, as I said before, if you have a particular interest in something that you don't have direct exposure in, you should try and use your elective periods, or even like your periods of time when you have summer holidays and stuff. Just spend like 2 weeks or 3 weeks in an area that you have an interest in, to try and get an idea. Because I remember before medical school, I had to do work experience in medicine as well as veterinary medicine before I decided that I didn't want to be a vet, but I wanted to be a doctor. So only through that are you really going to find out what you love and what fits best with you.
Okay, I just want to say a big thank you again, and I want to thank all the participants and the team at SCOME. Thank you so much for coming out. Please remember to message me your name and your contact number. So just a name if you want to contact Dr. Smith regarding any more questions, or if you want her to provide you with the information to get this required equipment that you need. So again, thank you to everybody. You may leave if you wish. Thank you.